I am one of our recent adds to the board of directors, and I am here to introduce Dr. Stufflebeam today. He is the director of the MEG Core Laboratory and Transcranial Magnetic Stimulation Lab at Mass Gen Hospital, and is an associate professor of radiology at Harvard Medical School, and an attending clinician in the Department of Radiology / Neuroradiology at Mass Gen Hospital. He is a graduate of Harvard-MIT Division of Harvard Medical School and did his residency in diagnostic radiology and his fellowship in neuroradiology at UC San Francisco. And I love UCSF. I just had to throw that in there. But yes, welcome Dr. Stufflebeam, and we're very excited for your talk today.
Thank you very much for the kind introduction. It's a pleasure to talk to you all. It's difficult for me to give these kind of talks because I'm not exactly sure what level I need to present the material with. So I sort of go the gamut from the very basic to the more advanced.
You're very tall.
So yes. Okay, is that better?
That's better.
Okay, so I'm just curious, who here has had an MEG or MEG? One, okay. Or know people who've had one? Yeah, okay, great. And what about TMS, Transcranial Magnetic Stimulation? Ah, great. So I'll introduce both topics. So what is the goal of surgical epilepsy, right? You want to cure the person of their seizures, or at least reduce the number of seizures so that it's manageable for the lifestyle. And you want to minimize the chance of damaging critical parts of the brain, like motor, vision, or language. So you do that by identifying the seizure onset zone within the brain and relative to eloquent cortex, so that the surgeon can remove that part of the brain or disconnect it so that they can hopefully cure the seizures. And this is done by finding the seizure focus, and MEG can do this. And when I say MEG, we typically also do the EEG at the same time. So it's both MEG and EEG. MEG is just a little bit easier to localize the source of the activity. So if you have an area on MEG that's highly suspect, there's a 70 to 85% chance of cure or reduction in seizures. And if you add an MRI, if there's a lesion and they co-localize, you have a greater than 90% chance of seizure freedom or reduction in the number of seizures. Now with MEG, you can also identify the eloquent cortex. You can map motor, language, vision, sensory cortex. TMS, by stimulating the brain, you can find the motor cortex. You can put temporary lesions on the brain to map out the language areas. And with the research is, with TMS, you may be able to disrupt the epileptic network, and it may be a future treatment for epilepsy. So I'm going to give an example of KS here. I know this is a pediatric epilepsy group, but her seizures actually started when she was 9 or 10. And she thinks the first seizure was probably 1972 or 1973. So that predates MRI and CT. So she didn't have any imaging. But she became seizure-free after adolescence. So from age 20 until 48, she was seizure-free on her medications. But she had a witness seizure, and actually by the director of the Martino Center where I work, where all our imaging is done. So she was a good friend of the director. and they were crossing the street in downtown Boston. She had a grand mal seizure, came to, and she said, that's the first seizure I've had in about 30 years. And he said, well, what has the imaging shown? He's another radiologist, and she said, I've never had imaging. He said, well, you've come to the right place. So she was actually visiting from Seattle. So she saw an epileptologist and a great group in Seattle, and there was planned to have surgery because she's now having 2 to 4 seizures a week. So the plan was to do a temporal lobectomy because there was a suggestion of a lesion near or in the left hippocampus. Because it's the left side of the brain, the left temporal lobe, they were worried about damaging language system. In most people, language is on the left hemisphere. So they were going to do awake mapping interoperatively of language. And if it was the dominant hemisphere, they would remove less of the temporal lobe to minimize the risk of damage to the language areas. And if it was the non-dominant hemisphere, they were going to take out more of the temporal lobe, including the entire hippocampus. So I discussed this with our neurosurgeon, and he said, well, just based on what I've heard, we might be able to do a more less invasive surgery. So we brought her to MGH and to the Martino Center for some imaging. So she had her MEG. This is the MEG device at the time. She has an EEG cap on, so we do both simultaneous EEG and MEG. So we're measuring the electrical activity and the magnetic activity of the brain. This is now the tech, this is Naro, who does a lot of the analysis. She also had an MRI. We always combine the MEG with the MRI, so we have both structure and function. She also had a 7 Tesla MRI, a very powerful magnet, and a functional MRI for language. So the MEG showed some spikes coming from the left temporal lobe. So these interictal discharges. On the 3T MRI, we could see some sort of lesion abutting the hippocampus. On the PET study, we saw a reduced uptake in the left temporal lobe. Near this lesion, which looks kind of heterogeneous, it has both dark and bright areas in it. That suggests some sort of blood breakdown products. Now, interestingly, she was left-handed, had this lesion in the left hippocampus. Her language was actually right hemisphere dominant. We could see that on the fMRI and the MEG. This is a still from a movie of the language area, and we can see she has most of her language function on the right side, which is fortunate because the lesion is on the left side. So on the 7T MRI, the very powerful MRI, we can see this kind of squiggly dark area. And this actually suggests that it is some sort of vein or artery that's probably clotted off. At first, this was thought to be something called a cavernous angioma, which is easier to remove surgically. It's encapsulated. But we thought, no, this is probably a thrombosed arteriovenous malformation, which is a little more tricky to remove. But it looks separate from the hippocampus, which is displaced right here. The white matter tracks, this is from DTI, showing the white matter fibers, the wires, going around the lesion. So she had this minimally invasive surgery where they went through the posterior part of the brain, removed this lesion, left the hippocampus intact, and she had no deficits. She had one seizure about 6 months after the surgery, but in 5 years since the surgery, she's been completely seizure-free. She's also had preserved memory. And in fact, when we did our memory task, she did the best of anybody we've ever seen. She only missed one question, where the average person probably misses 20 out of 100 of the questions. So this is the team for the MEG Core Laboratory. It's a little bit out of date. Matti Hamalainen has left us and he's gone back to Finland. He was the original core director. Naru Tanaka is one of the people who does a lot of the analysis. Tepe Matsubara also does the analysis. He's in this combined TMS MEG device, which I'll talk a little bit about. Seppo Alfors is the technical director. And David Cohen still occasionally comes in, but he's getting older. He's in his mid-90s. He's the father of MEG. He discovered it at University of Illinois in the late 1960s. Later moved to MIT, where he continued his research. Now he's one of the technologists. And Vasily here is a consultant now at University of Chicago. So the clinical history of MEG, 1968, David Cohen published his first paper showing the original MEG recording with an inductive coil, which was just wrapped wire put on the head, and did very careful measurements. And that was the first MEG. Later came to MIT, worked with Jim Zimmerman, who developed SQUIDs, superconducting quantum interference devices. It's a mouthful, but they are the sensors of the MEG. They measure tiny magnetic fields, several orders of magnitude below the magnetic field of the Earth. So the first commercial system came out in 1986. I lost my video. Okay. So it's been around actually for a long time. It predates functional MRI. In 1989, a system came out with 37 channels, which had enough to cover one lobe. Then you can combine it with the MRI and do source imaging analysis, or magnetic source imaging. And by 1993, they had whole head systems, such as the one we had here, which was installed at the Martino Center at MGH in 2002. The CPT codes, which is how we bill for this study, came out in about 2002, and we've been doing clinical MEG scans since 2006, and we've done about 3,000 patients now. And I've also been involved in some of the international and US MEG societies. So this is the older system, but I show this just to show how the patient is laid supine here and put into the helmet, whereas you can also do cognitive studies in the upright position. Now these are the SQUIDs, the little sensors. There's 102 of them in our system. Each sensor measures 3 components of the magnetic field. So we have 306 channels from the MEG. And again, we also do simultaneous EEG with the MEG. And so this is our new triac system from Megan, and it can also be put in the upright position or supine position. For the epilepsy patients, we like to put them in the supine position because we want you to get drowsy, go to sleep, because that changes the brain waves and sometimes can induce these interictal discharges. There's also now an intermediate position, so if you can't lie down, we can put you in a semi-recumbent position. It also has a helium recycler now, which is great because these SQUIDs require a temperature of about 1 degree above absolute zero, so minus 470 degrees Fahrenheit or 270 Celsius. And the helium boils off quite easily at just a few degrees above absolute zero, so we would have to refill this once a week. So that was a major expense. So what does MEG measure? It measures the magnetic field. So you can just think of this as a wire. And whenever there's a current, You might remember from high school physics, right-hand rule, you go like this, the current goes the direction of your thumb. This is the magnetic field. So this is showing a postsynaptic neuron with a particular current Q, and it makes this magnetic field B. This is what we're measuring with the MEG. This is a presynaptic neuron, and this is showing an action potential, which has mirror symmetric currents, so they cancel out. So we don't measure the action potential, we measure the postsynaptic potentials, which also tend to be longer, tens of milliseconds versus a millisecond. So these can sum up. You probably need about 70,000 neurons firing simultaneously to measure something outside the skull with the MEG. And so these are some of the pyramidal neurons here. This is the cell body. These are the postsynaptic tufts coming in, and this is the axon where the action potentials come out. So the current run in this direction. They can also switch polarity and run the other direction. But these are what we're measuring. And during the interictal discharge, you get many, maybe 100,000 or millions of neurons firing simultaneously. So we can easily measure the magnetic field outside the skull. Now the orientation is important. If it's radial, MEG is less sensitive than the fissural cortex. So this is sort of a mountaintop. It's less sensitive at the mountaintop, but as you go through the depth of the mountain, these are the neurons that we measure quite well with MEG. So there's a different sensitivity between MEG and EEG. This is showing a bunch of the sensors from a repetitive median nerve stimulation. So this is how we measure sensory cortex. The first little deflection here is at about 35 milliseconds, and that's the primary sensory cortex. There's a little dipole here. This is an equivalent current dipole. It's like a little battery put in the cortex. This is what we use to localize. The secondary somatosensory cortex is represented bilaterally. So this dipole comes from stimulation of the opposite hemisphere, whereas the later, about 70 milliseconds, is represented bilaterally, normally. And we can also measure the motor cortex. We put little electrodes on the muscle in your hand and have you move your hand. And that induces this 20 hertz rhythmic signal we can see on the EMG on these electrodes on the hand. And if we look at the correlation between sensors over the central area, which is where the motor cortex is, we can detect the the left motor cortex or the right motor cortex. And we can also combine that with the sensory stimulation, so we can get the foot stimulation or movement and the hand stimulation and movement here. And this is showing a tumor overlaid with the venous system. So this is how we do the presurgical mapping. So we will make a 3D representation of the brain by extracting the gray matter. We actually blow it up here. And so the light gray is showing sort of the tops of the mountains, or the crowns of the cortex. The dark are the sulci, or the little valleys within the cortex. And we do this so that we can see the activity, both the mountaintops and valleys. We can also use these to register to get a normal average, so we can compare to a normal subject versus something that might be abnormal. We also use landmarks on the MRI. This is the central sulcus, so this marks primary motor, and this is sensory cortex. This is the 3D rendering, and this is the blue is showing the central cortex. So what we do is we take the MEG signals and we identify either an equivalent current dipole, this point, or we can make these spatiotemporal movies. So this is a generalized interictal discharge, and what we're seeing is the activity on the cortex over time. So this is good for propagated activity, and this is good for activity that's focal. And we tend to do both types of analysis in all the patients. What's important for MEG is the location of the inner skull. So we do certain sequences on MRI. This one doesn't show much of the brain, but does nicely show where the inner table of the skull is, so that we can do this kind of modeling to do our source analysis. So this is a patient, I think this was about the 10th patient we did. This was from Children's Hospital. And this patient was 9 years old. They had thought they had frontal epilepsy, but the MEG showed that there were actually the discharges in the right temporal lobe. So these little red dots are showing where many of these interictal discharges came from. These little tails are showing the orientation of these currents. So again, this is like a little AAA battery within the brain. And so they're clustering actually in the posterior temporal lobe. And when we made the movies, we can see it starts in the temporal lobe and propagates to the frontal lobe. So it was thought this was a frontal lobe epilepsy, but it turned out to be a temporal lobe epilepsy. This patient had surgery. They did a standard temporal lobectomy, but it turned out that actually missed the cluster of dipoles. So the patient had recurrent seizures, came back for another surgery. Those dipoles were removed, and the patient became seizure-free. So I'm at the Martino Center for Biomedical Imaging. And what is that? Well, the short answer is it used to be called the NMR Center, or Nuclear Magnetic Resonance Center. That name was changed to the Martino Center when they made a generous donation in honor of their daughter. So she actually suffered from schizophrenia and was treated at MGH, and they were quite grateful, despite the fact that she ended up passing away, that they donated money to both MIT and MGH. And so now the Martino Center is a joint initiative of Mass General Hospital, Harvard Medical School, and MIT, the Division of Health Science and Technology. So most of the devices and imaging that we do there is research, but I run the clinical MEG service. We do some fMRI and 7 Tesla MRI as a clinical service. So right now we're located about here. This is where the Sheraton Hotel is. Boston Children's Hospital is over here behind Fenway. This is the Charles River. This is the Boston Harbor. Mass General Hospital is over here, abutting the Charles River. We are in the Martino Center right here is in MGH East, so it's across the Boston Harbor. And it's located in this building 175 and, 149 and building 75. There's a convenient parking structure. And at the Martino Center, we have not only the MEG, which is located in the bottom corner here, but we have an MR PET. We have a cyclotron. This 7T was the original 7T that was put in the same time as the MEG, but has now just been decommissioned about 2 months ago. We have another 7T MRI, and this one will be replaced with the latest and greatest 7T MRI. We also have several other 3T systems. We have the TMS system, which is located on the 2nd floor of the Martino Center. And over here is the Connectome scanner, which is now Connectome 2.0 with even more powerful gradients to measure the wiring of the brain, the white matter of the brain, to do that DTI imaging. So most of the Martino Center is centered around the MRI. So we take an MRI and we use software to extract the cortex. You can see in red here, I hope. I guess you can't see my pointer. So the red is the cortex or the gray matter, and that's where the MEG signals come from. So we extract that, we can inflate it here to make our spatiotemporal movies. The green is the inner table of the skull. So with the cortex and the inner table of the skull, that's all we need. We can then do our source analysis. To do the source analysis in the EG, it's more complicated. We also have to have the outer table of the skull and the skin. But we can also do source analysis with the EG. The TMS, which I'll talk about in a second, is a way to stimulate the brain with a magnetic field, and it's very good for mapping motor cortex. We use the MRI to co-localize things like radio-labeled glucose. So radio-labeled glucose is taken up avidly in something like a tumor and is less well taken up in the seizure onset zone. So we look for cold areas on the FDG PET. We also have optical imaging, which is using powerful lasers, and this is some of the tractography showing the white matter tracks on the upper left there. Okay, so what is TMS? It's Transcranial Magnetic Stimulation. In some ways, it's the opposite of MEG. So MEG, we're measuring tiny magnetic fields, femtotesla, less than 10 to the minus 12 Tesla. Very tiny. Whereas TMS, you put in a very strong and rapidly changing magnetic field. And what that does is it induces current in the brain. So you can stimulate the brain or you can inhibit the brain. So MEG measures magnetic fields. TMS stimulates the brain by a very large magnetic field. So you generate the large magnetic field with a wire. And so this is current coming in the yellow there, and the little loops. There's two loops with current going in opposite directions. That causes a current in the brain. So this is showing current induced in the motor cortex, and this is how we map the motor cortex. And so the basic principle is you have these loops of wires, big current, it zaps the brain, and then it'll cause your finger to twitch. You know, you can map where the thumb is, the index finger, you can do the foot, you can even do the face. So you can map the entire motor system within the brain, which is important prior to surgery because you don't want to damage any of the motor cortex. And it's completely non-invasive. It doesn't hurt. It's kind of a weird sensation to have your finger move on its own. But you just hear a little click, and that's it. And then your finger or hand starts moving. You can do it with the EG on, and you just move these paddles around to do different mapping. You can also map language areas, and that's done by temporarily lesioning the brain. So you zap the brain, it stops functioning, and so you can figure out where productive language is coming from or the receptive areas. So originally, TMS got FDA clearance to treat depression that's not responding to medication. Then later, it got approval for surgical mapping, particularly in epilepsy and brain tumor patients. And the most common is probably the motor mapping, and then the next most common is probably language. But you can map out virtually any other system, like the visual system. And the research is really exciting because not only can you map out the motor system, but you can perhaps disrupt or reset some of these epileptic networks so that this is a non-invasive way of doing something like deep brain stimulation, which currently is done, by inserting a wire in the brain and stimulating, the brain deep inside. You can actually do this non-invasively. So I think over the next 10 years or so, this may become a treatment for epilepsy for people who are not surgical candidates. It may replace RNS as well. So at the Martino Center, we have a clinical MEG that can be ordered, but the TMS right now is purely research. So if you want a TMS in Boston, Children's Hospital has one. And Dr. Pearl, Philip Pearl, who gave the talk across the way just before me, is involved in the TMS there. Alex Rottenberg is one of the epileptologists, and he runs the TMS lab. So I would contact him if you would like to get a TMS or be involved in that research. So as you all know, the surgical evaluation, the evaluation of the surgical epilepsy patient is a multi-layered process. There's many different steps. A history, a physical exam, doing a routine scalp EEG, high-resolution MRI, video EEG, or the so-called phase 1 evaluation, and a neuropsychological test. Most centers, I'd say 95% of the patients will have all of these performed. And then depending on the center, you may have the phase 2, or video with invasive electrodes, stereo EEG, or grids and strips. They may do electrocorticography, measuring the cortex during the surgery to figure out where the seizures are coming from, or to do functional mapping. The FDG PET, and then blood flow studies like an ictal-interictal SPECT study. WADA was done mainly to determine which hemisphere is dominant for language. This has sort of been replaced by fMRI, MEG, and TMS. So WADA required inserting a catheter up into the carotid artery, and then half of the brain was put to sleep. And then you can decide which hemisphere is dominant for language, or verbal memory, or spatial memory. But again, this has probably mainly been replaced by fMRI, MEG, and TMS. And then there's other things, such as the MRI volumetrics. So you measure the size of something like the hippocampus. You can see whether it's damaged and getting smaller, or the cortex. So areas that have thickened cortex could indicate something like a focal cortical dysplasia, which can be highly epileptogenic and a good target for the neurosurgeon. So this is something we're very involved in. So we have all these cool tools, and MEG, DTI, the invasive electrodes, TMS, PET, and the structural MRI. And what we can do is kind of just throw them all into a box, right? And then we can apply AI or machine learning. So some of these newer techniques. So using AI, what we've done is reconstructed, this is the MRI, and this is a view if you wear goggles, the HoloLens, and this is showing what the brain looks like. And if you look carefully, you should be able to see the little dots, which is the stereo EEG leads. And using hand motion, you can make the brain bigger, you can remove the hemispheres. The blue and the red are showing where the magnetic field goes in and out of the brain. And that was during a motor task. And what we hope to do is apply this to the surgical conferences, where we have everybody together, and this will allow everybody to sort of interact with all the data all in one space. And even people who may be in a different state or a different country can participate in the conference. We have some other desktop software to do similar things, where you can interrogate the brain, remove things, figure out where the fMRI is, where the MEG is, where the PET, SPECT, etc. Everything that you might want in a single location. And applying the machine learning is interesting. So this is some research that we've started where we put all the different complex imaging, MEG, PET, fMRI, etc. And then we display this as a network on the patient's individual brain. We morph it to a standard template brain. And then we extract features and have this very abstract mathematical model of different features within this network. And we're collecting a database. Right now we have about 1,200 patients, and we hope to have about 5,000 soon. And we can project them into this abstract space and cluster them based on their response to particular treatments. Then we can extract the same features in a new patient, compare it to our database, and then using the machine learning, it can tell you what's the best next step to take, if resection is the best treatment, and what the expected outcome is. So we think this is an exciting new way where we may be able to help guide neurosurgeons and perhaps show new treatments that you might not have thought of. So how is MEG used? So typically, the EEG, the history, the MRI, the PET scan, it's discussed in a surgical meeting. So there's an epileptologist, a neurosurgeon, neuroradiologist, psychiatrist, psychologist, and we have a discussion. Maybe the person goes straight to surgery, maybe they're not a surgical candidate, or we might recommend that they go to the phase 2 and have invasive electrodes put in. So with the MEG, we decided to siphon off the ones, instead of going directly to invasive measurements, have an MEG, have a 7T MRI, and sometimes that will guide them directly to surgery when we can bypass the invasive electrodes. Other times it could be that they're not a surgical candidate, it overlaps critical parts of the brain, so you'll recommend other treatments. And at the very least, you can have the most intelligent placement of the invasive electrodes. So nowadays, everybody gets an MEG, everybody gets an fMRI. We recommend that everybody gets an MR PET, and the 7T, if there's no lesion, but we still highly suspect a lesion, then they'll have a 7T. Otherwise, we bypass that. And then proceed to the surgical conference, and the same discussion is made, but now with all the information at hand. So the MGH surgical approach, this is Dr. Richardson, who's the lead epilepsy surgeon at MGH. He discussed the focused-oriented approach, which is what we had talked about, identifying the seizure focus, and then resecting it or ablating it, and then deciding whether this patient is seizure-free. Then depending on the outcome, you may look at other treatment options. And so this was a very linear way, and it's probably an oversimplification. And it's better to think of epilepsy as a network disease, that there's different nodes and they're all interconnected. And so you have to have a hypothesis of where and what the epileptic network is. And the idea is to take the epileptic network offline, either from a resection, ablation, or a network-specific neuromodulation, so that's RNS or deep brain stimulation, or perhaps TMS. And then you can then decide whether you have the outcome that you want. Otherwise, you restart, come up with another hypothesis, and repeat. So one of the fun things is deciding, which technology to use at what stage of the workup. So MEG also has other clinical applications. The most common right now is epilepsy. Brain tumors, somewhat. At some sites, brain tumors are imaged quite a bit, both for functional mapping as well as diagnosing the type of tumor. Other things like TBI, autism, dyslexia, and psychiatric disorders are probably coming in the future. So what are the indications for an MEG? It's to localize these interictal spikes, find the irritative zone, or define the epileptic network. That'll help with the placement of the stereo EEG or grids, also sensory and motor localization, and language lateralization. And often we do both. So we do a combination of the epilepsy and eloquent cortex mapping. So these are the CPT codes, are common procedural terminology codes. And I only mention these because these allow us to charge the insurance carriers. So most insurance carriers cover MEG for surgical evaluation. And if not, we have ways to appeal it. And our billing department will assist in all of this. So what to expect? You can eat normally before an MEG. Generally, we schedule the MEG in the morning because we like you to go to sleep or have your child go to sleep. And it's okay to wake them up a little bit early. We don't want true sleep deprivation, or a normal night's sleep. And we change you into a gown. The MEG is entirely passive, so it's quiet. It's not like an MRI. So we'll put on a cap, we'll digitize the head, and then put you into the MEG. Sometimes if the head is small, we may move it around to get closer to the sensors. That improves our signal to noise. We digitize the head so that we can easily co-localize it on the MRI, like this auricular point on your ear is easy to find on the MRI, particularly when you have a 3D rendering like this. So this point, and then we can register it to the MRI. We also digitize a whole bunch of other points, and then we have computer algorithms that tries to minimize the distance of all these spots so that we have perfect co-localization of the MEG and the MRI. So what are the future directions of MEG? There's something called optically pumped magnetometers, which use lasers. So instead of the squids, which have to be super cooled and bathed in liquid helium, the OPMs use a laser, and the magnetic fields change the frequency of the laser slightly so that you can actually measure magnetic fields. And this has allowed us to develop things like combined MEG and TMS. So if we took a normal TMS, these coils, and put it in an MEG, you destroy the machine. We'd have to buy a new one, right? Because you're making this gigantic magnetic field. It would burn out the MEG. However, with these new OPMs, we can switch them off quickly, and they're not damaged by the magnetic field as long as they're turned off. So Yoshio Okada and, at Children's Hospital and MGH developed a system which combines TMS and MEG. This is a prototype, and we're still in the prototype stage. So it's not in use yet, but we're hoping over the next few years to get volunteers and then perfect it. What's nice about it is instead of just one big giant coil outside the head, we have 16 steerable TMS modules, so we can more precisely localize where the TMS goes. So not only can we do simultaneous TMS and MEG, but the TMS is much better targeted. So I hope I gave you a nice introduction to what clinical MEG is and TMS, and I'm happy to take any questions that you might have. Thank you.
So is MEG well well tolerated by young kids?
For the most part, yes. I mean, I think a toddler can be a problem because you do have to hold still somewhat. So it depends on the age and how cooperative they are. Most kids we're able to do. Now, we can't do sedation or anesthesia. If you need that and they're toddler size, you can go to Children's Hospital. They have a special MEG for smaller heads. But for the most part, we can do kids. We've even done infants. You know, you can wrap them up in a blanket and put them in there. Those are the ones you have to move their heads around a little bit. We also have groups that help us, you know, with kids. So we might bring them in a few times, have them get acclimated to the MEG, you know, bring their stuffed animals, have their parents in there. And that we might do that 2 or 3 times before the actual measurement. But we've been very successful. I'd say, you know, 95% of the kids we've been able to do without having to resort to anything.
And for MEG, fMRI, and TMS, how accurate is it? Like, what kind of confidence would you say, okay, I've localized movement? Are you
Right.
sure? 90% sure?
Yeah, I mean, I think with the TMS, because you're directly stimulating the motor cortex, you're very confident. With the fMRI, what you do is you have them like squeeze a ball. Now, what that does is it activates both sensory, you know, your tactile sensation, and the motor cortex. So it's a larger blob. The TMS is much more focal. You know where it's coming from. And same with the MEG. You can do the motor localization with a bit more accuracy than the fMRI. If you have all 3, we're quite confident that you have the motor cortex at least. Language can be a little trickier. With TMS, you know, you're doing a temporary lesion, and that doesn't stop you from speaking, but what you do is you make errors. So you have to figure out, you know, how many errors you have with a lesion in a particular part of the brain. So that's a little trickier. But I would say a combination of the MEG and fMRI with language mapping, you're quite confident. Yeah.
So if I want my child to have a 7T MRI
Yeah.
TMS, but they're already at a level 4 epilepsy center that doesn't offer those, can I just phone you up and
They
say,
can-
please do this? Or-
So it's usually better to have, you know, that somebody from the team call us up. So we have a fax number. They can call us, you know, or send us a letter. It can be ordered. Or you can call us directly and we can get in contact with your clinicians. We do that all the time. Yeah.
Person currently has quite a lot of medication to not have seizures, but they want to do this, they have to be off the medication? Or maybe they're-
No, so we typically do the interictal studies, so they're not having the seizures. So we don't wean them off the medication. We're an outpatient facility. Some of the MEGs are inpatient and they will wean them off of medication and get ictal studies. We're not offering that at the moment.
Only time for one more question.
One more question, okay, yes.
You mentioned we were doing a study in Nashville. Can you tell me what was that study that you're doing?
So that was a database study. So we're taking patients who've had all these different imaging modalities and the invasive electrodes and have had surgery. So we have their outcome. We're putting all that into a database so that we can extract the features and figure out, you know, what's most relevant for which treatment type. But we're also doing studies with the you know, TMS MEG, the OPMs, the new kind of MEG. You know, and who's taking volunteers there. So if there's any study you'd like to volunteer for, or, have your child, we're happy to do that. You just give me a call or send me an email.
Thank you.
All right, thank you.